All right, it is 11:31 and I cannot wait to learn from Tony and Peggy. So we're going to go ahead and get started. My name is Michelle House, and I am the program administrator for Deaf and Hard of Hearing Services at the Department for Behavioral Health, Developmental, and Intellectual Disabilities. And what that means is that I get the privilege of getting to look at our systems and see how we can make communication access better across the board for mental health, substance use, and developmental or intellectual disability services. And I get the opportunity to work with wonderful people, one of whom is Jeannie Taylor. Jeannie is our advisory committee chair. We have an advisory committee of 16 members, half of whom must be deaf or hard of hearing themselves, so that as we're designing these system changes and developing new programs, we're not doing it from Frankfurt in an office, but we're doing it with the community, and that's the best way that this should always be done. On our call today, we have people representing community mental health centers, recovery community centers, developmental and intellectual disability services, state facilities, administrators, clinicians, peer support specialists. All of us need to work together to improve access. And today is just part of our conversation. Many of us have been in conversation for years, some for weeks, some for days. But this is part of that continuing conversation. As you have questions today, you can put them in the chat, and we will wait until the end for questions, but I will be able to prompt Tony and Peggy if there's any burning questions that were in the chat earlier. And then if we don't get to everyone's questions, we'll create an FAQ, and we may have follow-up workshops, because there's no way we're going to learn all we need to learn in an hour and a half. But I'm so glad that you are here today. We also have a rainy day in Kentucky. So if my internet goes out, we have Tony and Peggy as backup hosts. Whatever happens, technical wise, we're going to do this with grace and humor and flexibility. And we have special thanks to our communication facilitators today. We have Julie Buckham and Jessica Mingus as our ASL interpreters. And we have Jenny James as our CART provider. So with no further ado, I would really like to have first have Jeannie introduce herself and talk about why this is so important and why you and I wanted to have this workshop today.
Exactly. Thank you, Michelle, for giving me just a few minutes to talk to you all. My name is Jeannie Taylor, and as Michelle just mentioned, I'm the current chair of the Advisory Committee on Need for Services for Deaf and Hard of Hearing People in Kentucky. So our advisory group is charged with developing a biennial report. And within that biennial report, we identify unmet needs, and then we also identify ways to address those unmet needs within the state of Kentucky. So our most recent biennial report was published and released back in the summer, probably June, July-ish. And in that report, we identified the ongoing need to assure effective communication at all points of service within our mental health communities, within our community mental health centers. So that was one thing that was identified. And so along with that, we also determined that a way to address that particular need would be to incorporate communication access plans into annual documentation for any individual with hearing loss in a state monitored or state funded program. So we've identified the need, and we've identified a potential solution to that need. A couple of weeks ago, our advisory committee met for a quarterly meeting, and during that meeting, Michelle arranged for our members to have a training and a presentation on how to develop action steps to address those needs. A lot of good things emerged from that training, but one of the most important things that emerged was a subcommittee was formed on access to supports. So in the coming year and the year following, those subcommittee members will be focusing very intensely on how to improve access to supports. And that's one reason why we have Peggy and Tony with us today. And we're so excited that they're here. This is a very important subject to our advisory board and also to people across the state of Kentucky with hearing loss. And sadly, we know that sometimes hearing loss and deafness leads to misdiagnosis and sometimes poor assessments, sometimes unintentional harm with negative consequences for the patient. So we want to do everything within our power to make sure that that doesn't happen. So we appreciate you being here with us today and hope you plan to learn as much as we do. Thank you.
Thank you, Jeannie.
Welcome.
So I'm going to invite you to turn off your camera and hang out and learn. And we will be now hearing from Tony Iacolucci and Peggy Ellertson. So please introduce yourselves. I'm going to go off camera as well and just cue me for PowerPoints and whatever you need in the background. Thank you so much, ladies.
Thank you, Michelle. And thank you everyone for attending our session today. We're extremely excited about the opportunity to share with you some of the things that we've learned about this very important topic. We're going to start by sharing a little bit about our personal histories. I have a profound hearing loss and was fortunate enough to be able to get a cochlear implant in 2018, which has been a real game changer, along with some other very significant game changers in my life, which I'm going to tell you about. My history is a little bit interesting in that just as I was completing a bachelor's program in communication disorders and was about to start a master's program, I was diagnosed sort of by accident with mild sensory neural hearing loss. My department head at my college had gotten some new audiology equipment and he wanted to work with it. And so he asked the graduating seniors if we would step up and have our hearing evaluated. And sure enough, I was identified as having a mild sensory neural hearing loss. What's important about this is that at this moment in time, there was an intersection with a period during which my mother's functioning, because of her by then profound hearing loss, had really begun to become quite visible. So it left me with a lot of questions and a lot of anxiety about what hearing loss was going to mean in my life. She lived with a great deal of stress and what we now know to be auditory fatigue. And just as I was finishing my master's program, she was hospitalized for a hip replacement, which triggered a very intense period of anxiety. In retrospect, I'm quite certain that the fact that she was not able to hear her physician talking to her or to my father about her was very likely a factor in her anxiety. So fortunately, I've been able to access some pretty remarkable resources for which I am eternally grateful. It just is serendipity that I'm a speech pathologist, and therefore I have access to a lot of resources through the American Speech, Hearing, and Language Association. There are special interest groups that, there's one in particular that teaches hearing healthcare professionals about patient-centered care. And so having access to that material has sort of broadened my sense of a toolbox for managing hearing loss. It's not just hearing aids. It's not just one thing. It can be a whole combination of things. I also, like Jeannie and Tony, was able to participate in the peer mentoring program through Gallaudet University, which was truly a remarkable experience during which I met many people just like me who lived with hearing loss and worked with master providers in understanding the toolbox concept, that there are lots of different approaches to communication access. And then finally, Hearing Loss Association of America has been a huge part of my life. I've developed deep and meaningful friendships through HLAA, and also, importantly, we've had the opportunity to try to make the world a better place for people with hearing loss. And I'm just going to leave you with one anecdote about my story. I have had two significant medical encounters myself, during which my providers were not prepared to give me any kind of reasonable communication access. And those experiences have really fueled my passion for this work. So I am now going to turn the mic over to Tony, and she's going to tell you a little bit about herself.
Thanks, Peggy, and thank you everyone for having us here today. This is the most important work I think I've ever done, and I think Peggy will say the same thing, that communication access is absolutely so critical in every areas of our life, but especially in medical encounters. So I'm going to breeze through my history because we have lots of other stuff to share today. So essentially, I started to notice that I was having trouble hearing in my early 20s. And like for many people with hearing loss, there's a whole lot of stigma attached. My father had hearing loss later in life. And, you know, we always see our parents as being incredibly old. And I did not want to identify with an older population. And usually the amount of time it takes someone from being diagnosed with hearing loss to starting to use hearing aids or some kind of assistive technology is about 9 years. I think it was about 10 years before I started. So there is that huge issue of stigma. That's a real barrier to our care. So in my hearing, finally in my late 20s, I did get my hearing aid, and it was helpful, but I wore my hair long and I would not tell anyone except for a very few people that I had it. And I thought I was faking that I was hearing, but I don't think I was doing a very good job. Probably a lot more people knew about it than I thought. So in my early 40s, I suddenly lost the hearing in my right ear, and it was really terrifying. And I was tested immediately. They did not find out. They didn't see anything wrong. There was a suggestion that I should have more testing, and that was never followed through. I did not know that was in my record. In any event, several years later, they realized it was an acoustic neuroma, which is a non-cancerous tumor near the auditory nerve, which destroyed the hearing in that ear. My left ear continued to deteriorate. And I still wore the hearing aid in that ear. And then in 2006, I was at a concert, and it was something very important to me. And I was always very careful about taking out my hearing aid and plugging my ear. And I said for that night, I'm just going to listen to the music. Sure enough, the next day, my hearing had gone down. My tinnitus, the ringing in my ear, was really wicked, and it continued to deteriorate. At the end of the week, my audiologist hospitalized me to give me steroids to try to bring back my hearing, but it didn't work. So in 2006, I left the hospital to live the next 15 years in a soundproof booth. I could not hear a single sound, a single word. I had to rely on speech reading and captioning for the most part. One specific event that was really life-changing for me was in 2011. My brother was very ill with cancer, and he was hospitalized in New York City where I lived, because he lived out of state. He was being treated here. So I was his designated point person. Long story short, I repeatedly asked for CART, which is someone to type for you. I'll explain later on, so that I could read captions of the discussions with doctors. And I was never given any accommodation except for a typist from their pool once in a while, and that was completely inadequate. So imagine going through 2 years with 4 doctors standing in front of you, giving you life and death information about your loved one, and not being able to hear a single word. I was given sign language interpreters on a few occasions, even though I kept specifying that I'm late deafened and I do not sign. So when my brother passed away in 2013, I decided that I was going to make a change and do something positive about this so other people with hearing loss wouldn't have to live through this. So I was already a part of HLAA, which was life-changing and helped me to cultivate a love for advocacy. And I knew Peggy, and we decided to join forces. So I'm going to let Peggy take over from here and tell you more about that.
Thank you, Tony. Michelle, will you show the first slide, please? And the next slide. I'm going to walk us through our very basic agenda. I will start with an overview of HLAA's Communication Access and Healthcare Program. And then we're going to talk about removing barriers, because that's what this is about. I'll be giving you some information about documenting hearing status and accommodations. Tony's going to give you a wealth of knowledge about auxiliary aids and services. And then I'll talk a little bit about evaluating aids and services. Please enter your questions in the chat, and you'll be getting a PDF of our slides when we're finished. There will be a link to our email box. And if you have other questions, please do not hesitate to be in touch with us, because this is the kind of work that we are focused on doing, sharing with providers what we know about this issue. Next slide, please. So HLAA has always been focused on the importance of communication access in healthcare. And for the first many years of HLAA's existence, the focus was on helping constituents with hearing loss self-advocate, giving them tools and guidelines, and also information about issuing a complaint if access was not provided. In February of 2020, one of the things that began to become apparent was that there were at least 4 of us who were very concerned about this issue. So the board of directors and our executive director, Barbara Kelly, put their heads together and decided to formalize the work that we were doing into a program, and that is the Communication Access and Healthcare Program. You've heard a little bit about Tony and me. Our other 2 strategic team members are Meg Walhagen, who is a professor of gerontological nursing and a geriatric nurse practitioner in the School of Nursing at University of California, San Francisco. Meg also served as the former chair of the HLAA Board of Directors, and she's heavily involved not only in instructing nurses who are in training, but also in public health research. Elaine McCaffrey is a former attorney who is the president of the HLAA North Shore, Chicago North Shore chapter. She is currently serving on the board of directors, and she's the creator of HLAA's Hospital Safety Program, which is a terrific program, sort of in webinar form, that has included providers and administrators from hospital systems in the Chicago area with constituents with hearing loss. And they talk about the issues and the kinds of resources that are being implemented in the Chicago area. You'll be able to access that webinar for at least the next month, because our website is being reconstructed. But if you go to the webinar tab on the current website, you will be able to watch that video. And if you're not able to access it, just be in touch with us. Next slide, please. We have developed some very helpful and important affiliations. Most notably, I'm going to talk about the Disability Equity Collaborative, because it's a group that you want to keep your eye on. They work out of University of Colorado Anschutz School of Medicine, and Megan Morris are one of our 2 research Advisors is the creator of DEC. DEC is made up of a remarkable collection of ADA coordinators and healthcare providers, administrators. There are some representatives of major companies that provide electronic health records. And out of the DEC come very important research questions and public health research related to communication access in healthcare. We also work with Nick Reed from Johns Hopkins, who is an audiologist and public health researcher. And then Lisa Hamlin, our beloved public policy advisor, who is also HLAA's public policy chair. She's been enormously helpful to us in understanding the public policy aspect of this issue. The next slide, please. So this is a statement that was compiled by Tony and her colleague Jody Prysak when they were creating the communication access plan. They did a lot of digging, looking at various characteristics of effective communication, and they created this statement. Effective communication occurs when information between two or more people is shared or exchanged, and each person is able to fully understand and make decisions based on that information. This is often a process that requires going back and forth with questions and answers until everyone has a clear understanding. This statement is foundational to our work, and it sort of captures the goal that we are after. This is the process that we would like to see incorporated in medical encounters. Next slide, please. Another important concept related to our work is that when we began, the four of us began to work together and have discussions with some of our stakeholders, one of the things we began to realize is that barriers to effective communication certainly affect patients, most notably in that many times it's really up to the patient to find the communication resources and make sure that they're implemented. So the burden is placed on the patient, him or herself, or on the patient's companion. But in fact, providers are profoundly impacted by barriers to effective communication. Many healthcare providers enter the field of their work without any kind of preparation in the care of people with communication disabilities. And certainly hospital systems are impacted by these barriers because with a reduction in patient satisfaction comes a reduction in the patient's reimbursement. So this is an issue that has far-reaching consequences for all three stakeholder groups. Next slide, please. There's quite a bit of evidence about the results of both positive and less than optimal communication in healthcare. There are lots of large studies that have yielded this data. One of them out of the Medical College of Wisconsin in Milwaukee identified the close association between when the patient has the perception that the provider is a good communicator, is taking the time to make communication access a priority, the tendency is that the patient builds trust in the provider. It sort of solidifies the collaborative relationship between the patient and the healthcare provider. On the other hand, we know, especially from some of the work that's come out of Johns Hopkins, that untreated hearing loss, and that's been identified as hearing loss that does not have any kind of accessibility technology provided, yields less good healthcare outcomes, which include significantly longer inpatient stays, higher 30-day hospital readmission rates, increased overall healthcare costs among persons with untreated hearing loss, and increased dissatisfaction with healthcare. And one of the details of one of Nick Reed's study is that for patients who are 75 years old and older, there is an increase in dissatisfaction with every 10 decibel increase in hearing loss. So the more significant the hearing loss, the less good is the satisfaction of the patient with the healthcare. Next slide, please. So I'm going to talk just a little bit about the first steps toward removing barriers. The next two slides are slides that we think are extremely important, and they have to do with getting the patient's hearing status into the patient's medical record. So we're talking about the importance of directly asking patients when they register for an appointment whether or not they have a disability, a hearing disability, that would be benefited with the use of accommodations. It's important to not only ask that question, if the patient knows he or she has a hearing loss and knows what the accommodations are, or even if the patient just has a hunch, to get those bits and pieces of information into the patient's medical record. Also, not only to ask, but to tell the patient why you're asking. You can share with the patient that in getting this information, you'll improve the quality of the healthcare visit. What you want is a good outcome for the patient, and you want to also help the practice identify and provide for the needs of the patients with hearing loss. The DEC has done work looking at the comfort level of patients who were asked the question. And one of the interesting findings of one of their studies is that 94% of patients with and without disabilities reported feeling quite comfortable disclosing their disability status. So that's the good news. Sometimes, as Tony mentioned, stigma is in play, and so the patient may be reluctant to disclose the hearing loss, or the patient may be more focused on whatever the healthcare issue is, getting it diagnosed and treated. There are a multitude of reasons why a patient might suspect hearing loss or know about hearing loss and not share that information with you. So what you want to look for is the patient who is asking for repetition of information quite frequently, or if the patient appears to be inattentive to what you're saying. And in those cases, if you have an idea that perhaps this is someone who's struggling with hearing, there are some low-tech steps that you can take to facilitate communication. And Tony's going to be talking to you about those low-tech tools. Next slide, please. The benefits of incorporating the hearing status and accommodations into the patient protocol are far-reaching, and I can't stress this enough, that having that information in the medical record and then having the healthcare team pay attention to that information really builds awareness among providers who make up the patient's care team. Also, once the information is in the medical record, it gives the providers and the healthcare system time to prepare and make arrangements for what's going to be needed for appointments. This practice reinforces the incorporation of accommodations into the patient protocol overall. So now we have a poll for you. The poll is going to ask you the question, do you feel comfortable asking your patients if they need assistance with communication access? And you're going to have 5 choices. You can answer yes, you can answer no, you can answer I don't have time, or I need more ideas about how to do it, or we have great conversations about access. And Michelle is going to pull up that poll now. Michelle, will you let me know when everyone has entered their response?
This is Michelle. Yep, we are at 61% who have participated. So far, we have a very educated crew or very comfortable crew who's very confident, with 62% being confident, 23% saying no, 8% saying I don't know how to pay for it, and 8% saying I don't know where to look.
Interesting. Well, it's good to know that 62% are comfortable and asking the question. It's interesting that it's an issue that's prevalent enough that DEC has started to look at both the rate of asks and also how patients respond to the ask. So thank you for that tool. And now I'm going to turn the mic over to Tony, and she's going to talk to you about aids and services that are available for people with hearing loss in healthcare settings. Next slide, please.
Tony, you're on mute. If you can take yourself off mute, please.
I live in New York City and there are sirens outside. I was trying to spare you. Okay. So I just want to go off script a little bit because a couple of things came to mind when Peggy was speaking. First of all, back to the poll. Can we take that off the screen? I'm still seeing it. Maybe I need to take it off. Let me try. Okay, I have it off. First is when someone in there was a percentage of people that said they did not know how to pay for the services. And I would just like to say that under the Americans with Disabilities Act, the ADA is the facilities are responsible for paying for communication, access, aids and services, accommodations that people need to communicate effectively. So the patient or the patient's companion never should have to pay for anything like that. So I hope that answers that a little bit. Also, I'm going to show you a lot of information in the slides. Don't worry about it. Michelle is going to make the slide deck available to you. So I will touch on some things and other things I won't. So you don't have to pay that much attention. Don't worry about it. Secondly, I talked before about my hearing loss. I want to mention something about my hearing gain. I also received a cochlear implant 2.5 years ago, as Peggy has, and that was indeed life-changing. I went from living in a soundproof booth for 15 years. I now would say in my right ear, which was the implanted ear, I hear about 85 to 90% of what I did before I lost my hearing. I could talk to people, I could talk on the phone, I could listen to music. I have a life again, and it's quite amazing. However, I still, although I can hear, I still need technology. When I speak to a doctor, there are still a lot of issues where physicians are not aware, or hospital staff or facility staff are not aware of hearing loss and its implications. So I still have to do a lot of awareness raising and a lot of accommodation asking for as I move along. I recently had a doctor's appointment and I said, maybe I should take my implant, my processor off and put myself back into being deaf. So I really remember the struggle. So I was in the waiting room and I said, okay, I'm going to wait till they call me. And then I said, because I probably won't hear them. And then I said, okay, I'll take it off in the doctor's office. And then I said, well, she's going to ask me a whole lot of questions and I'm going to have to struggle. P.S. I never took it off. And what gaining some of my hearing back has taught me is how hard it was not to hear, not just for me, but for the providers. And I will say now to everyone that I speak to or work to in healthcare facilities is that I would be absolutely terrified to be in your shoes and to be talking to a patient or a client and not being quite sure that they could hear what I'm saying, because that can be very unsafe for everyone. So I will get back to that later. Okay, Now, back to where I was going to begin. Auxiliary aids and services, that is the ADA term for accommodations. Very important to remember that accommodations have to be suited to the patient's individual needs. We all have different levels of hearing loss. We have different levels of speech recognition. We all hear and don't hear different things. Some of us are very social. Some of us continue to work. So our needs and the accommodations, the auxiliary aids and services that will help with that will be different. So it's very important to get to know specifically and to ask the patient what they need. We are the experts on our hearing loss, although some of us are not aware of accommodations and still have much to learn. Secondly, the ADA mandates that companions, that's the ADA term for friend, spouse, any person who is there to support you in your care, that they have the same right to aids and services as the patient. I did not know that when I went through that 2-year experience with my brother. Had I known that it was my right to have communication, I would have demanded it. I thought I was asking for a favor at that point. So the whole situation would have ended very differently. Surprising. Many people with hearing loss don't know this. So this is something to spread around, and you're certainly helping yourself. You know, we want people with hearing loss to be able to manage their health care independently, but they can also be a great source of support for the patient and the provider. So it's in your best interest to accommodate them as well. And this is something I feel strongly about. I don't know, my slide looks a little skewed here. I don't know why. The medium is the message and wording is impactful. Through the years, currently, the term that's always used in medical facilities and outside of medical facilities to refer to our population is deaf and hard of hearing. In actuality, there are 48 million Americans with hearing loss, and there are only 1 to 2 million deaf Americans who use American Sign Language. The wording here really takes the focus off of the larger population of people who can't hear. I think it's why there's this strong orientation to think that as soon as you say you have hearing loss, it means you need an interpreter. A couple of weeks ago, I had 2 subsequent appointments at the same facility, one for an MRI and then for a follow-up consultation. I knew because I'd had these tests before that I could handle without accommodation, without card. So I did not ask for it. However, on both occasions, I got sign language interpreters. And after the first week, I said, I was in the same facility. Okay, you made a mistake. Please put it in my record. And this is the same place that I was at with my brother 10 years ago. And sure enough, when I came back the next week, I got a sign language interpreter. Okay, so the hospital is wasting money. They're not listening. It's not going into the record. So this is a really important issue. But the bottom line is kudos to the deaf signing community. They have done a phenomenal job of making themselves heard, of talking about their needs and getting the accommodations that they need. People with hearing loss really need to learn from that. Because of the stigma and everything else, we have not been as good at doing that. But I really encourage people to think about reversing that to hard of hearing and deaf, since we are the much larger community, and so people will be more aware of that. But the good news is both communities, hearing loss and the signing deaf community, now use a lot of the same technology, et cetera. So we have been able to do a lot of work. HLA meets with a lot of organizations representing deaf ASL community, and we've been able to work together. So that's really great news. Okay, next slide, please. Okay, so I'm going to talk about low-tech options for aids and services, and then I will go into higher tech options. The first one is effective communication strategies. So I'm going to focus on that a little bit first. Next slide, please. So here are some strategies to remember. First is to think hearing loss. Peggy really touched on this when she talked about asking if people have hearing loss or observing if people look like they're not hearing or they're not really understanding information. The numbers of people with hearing loss are greater and greater as time goes on because we have a noisy world. Half the people over 75 here at 80 here at about 50%. So there are 40 million people out there. I would guess you have patients with hearing loss. So always try to be aware of that. Second is to get the patient's attention before speaking. You will save a lot of time on this because when I was profoundly deaf, if a provider was standing to my right and I was looking off this way, they could talk to me for 20 minutes and I would not know they were speaking to me. So someone always has to make sure they get my attention first. You have to maintain eye contact. All doctors, all providers, I keep saying doctors, I'm sorry, because I'm so used to working with hospitals, but all providers have a habit of looking at their computers, which is just sort of off-putting in general because you don't feel so engaged with your doctor. And there's been a lot that's written about communication with people that do not have hearing loss. So this is something for everyone to remember. I was seeing one of my doctors and the way his office was set up, I was sort of behind him and he was facing his computer and I had to keep reminding him to turn around and look at me when he spoke to me. And I was quite elated. The next week I came back and he'd moved the chairs so that I could see him as he was writing in his computer. I was facing him, so it was much better. Be sure the patient can see your mouth clearly because many of us speech read, but do not rely on speech reading. It's difficult, it's exhausting, and it's not perfect. I think something like 40% of speech sounds are visible on the lips, and you're also looking at facial expressions, but it's not something to rely on, but it helps. So make sure that people can see your mouth. Speak clearly and at a moderate pace. Do not exaggerate or enunciate. It makes it more difficult for us to understand. This is an important one, rephrase rather than repeat, because of the fact that we hear differently. Different people with hearing loss hear differently. Some people hear certain speech sounds, others don't. Some need it louder, some don't. If you keep saying the same thing over and over again, if it doesn't work after 2 times, we won't get it. So instead of saying, I want to see you in 3 weeks, if you keep saying that and someone's not getting it, you would say, we have to have another appointment. So I will have you come back in 3 weeks. So just change it around. You'll be using different sounds, different words, and you'll have a better shot at getting your message across. Lastly, second to last, use visuals, pictures, diagrams, charts, and I urge people, less is more. Keep it clean and simple. With hearing loss, you're focusing on so many things. You're trying to process what's being said, to understand what's being said. And then when you have to look at very complicated diagrams, it's just really exhausting and not as productive. Lastly, strategy which is extremely helpful is teach back. But I'm going to leave that for now because Peggy's going to touch on that later on. Okay, next slide, please. Okay, we'll go back to the low tech options. The second one I have here is pad and pencil, and I want to share a kind of fun slide with you. Next slide, please. So I went to the Massachusetts Museum of Contemporary Art to see this wonderful exhibit. And this is a man who was late deafened like Peggy and I, and lost his hearing rather suddenly, and all of a sudden was unable to communicate. What he had to do, I guess he was not very good at speech reading, and he needed to augment that no matter what, was he started writing notes back and forth with his friends, with his family, because that's the only way he could really hear. And when I became profoundly deaf after I lost all of my hearing over a week, I had to do a lot of that as well. And it's pretty interesting because people seem to share share a lot more with you in writing that they do in terms of what they say with you. So, you know, we all stand, there were 2 huge rooms like this that were circular. There were just hundreds and hundreds of notes. So, you know, you start reading them. And this is one that absolutely caught my eye because it so goes to the beauty of a simple solution, in this case, pen and pencil. And this was obviously written to a dentist, or a dentist writing to a patient. Next slide, please. So it says, Advil or Tylenol, salt water and brush gently. It will get better in 3 to 5 days. Plain and simple, clear as a bell. Okay, so there is a lot of validity to using these low-tech solutions. Next slide, please. Also, and another benefit to low-tech is as we go through this, there are things that you could just keep in your offices. You don't have to go to a special place. They're $10 or less. And they're just very easy to have on board and to use. So the next one on the list is a whiteboard and a marker, which you could also use like the previous note about the Tylenol. It's very easy to use that because then you just wipe it clean when you're done and you write another one. The writing is usually larger, but you could also use a tablet, or the provider could use their computer for typing to you. And then written materials, again, the ADA mandates that they should be written in plain language. There's even a plain language dictionary online, which we use that when we wrote the Guide for Effective Communication. And it's a wonderful resource because it really makes you think about how you communicate with people and how they're going to understand you. Again, the messages should be clear and concise, and simple images are helpful. Lastly, clear masks. I don't know how many of you have seen them. They can be very helpful. In the surgical masks, there is an opening here. It's clear, so you can see the physician's mouth. They are really helpful, but again, there is danger in just expecting a patient to be able to speech read everything you say. But they are helpful, and every person with hearing loss should have the option to have their provider use one of those. It's also kind of good to see if someone is smiling, if they look concerned, because we're not just reading lips, we're looking at facial expressions. Okay, next slide, please. Okay, these are the higher tech options. So what I'm going to do here is, I'm not going to keep this slide up because I will go back to it at the very end, but I'm going to give you some visuals on the different aids and services that I'm talking about. So let's go to the first slide for sound application devices. This is a pocket talker. What it does is it's simply a sound boost. The doctor speaks into the microphone, that little rounded thing that juts up on the silver pocket talker itself. And then the patient can wear the headphones. And what it does is it makes speech louder and clearer, especially if you're in a noisy setting. Again, you have to look at the patient's particular needs. When I was profoundly deaf, that would not work for me. I could have all the sound in the world, but I couldn't hear it. Even now with my implant, I cannot wear that kind of device, and I can boost the volume on my phone that Bluetooths to my implant. So it's not necessary. So this is not for everybody. One thing that's really wonderful about pocket talkers is we've heard providers discuss how patients will come into an emergency room or whatever, and they have hearing loss, whether they admit it or not, but the provider senses that they're not hearing and may offer a pocket talker. The person puts it on, starts listening, and it's life-changing for them because they did not know that there was a solution, that if the volume was a little bit higher, they could hear better. And if it was going directly into their ears, they could hear better. And on occasion, this will prompt someone to finally make the move to go and try and get a hearing aid. So it can end up being a segue to a more permanent solution. Okay, next slide, please. These are speech to text apps. They are also life changing. I pretty much lived with speech text apps on my phone once they came into existence, not that long ago, but before I got my implant. Not only did I use them for my medical encounters when I could, but I used them when I went to the store, when I talked to my friends. It was instant captioning. There are a couple that we have and our colleagues have found to be particularly helpful. One is Live Transcribe, what you see there. It's quite accurate. Peggy and I just did a bit of a experiment with some of the Google devices. Live Transcribe is Google. And they gave them to some folks in hospitals to give it a try, and people really like them. They're also good because what you could do is you could also look at Live Transcribe on a laptop. So if you're having an encounter, a medical encounter, both the provider and the patient can see what's on the screen, so that if there's a medication or words that are spelled incorrectly, it's not perfect, but it's very good. If things are incorrect, the doctor will see that and can correct them to make sure that there are no errors. So Live Transcribe is for Android, although you can use it on your laptops. It's excellent. A second one that a lot of folks use on their iPhones is Otter AI. Again, very accurate. You get, I forget how many minutes for free, and probably more that you would ever use for your patients in a year. So I don't think you'd have to pay for it. Another point is now patients are pretty much allowed to use them in hospitals, but we really encourage hospitals to provide the technology instead. The ADA says that it's up to the patient to disclose their hearing loss and to ask for aids and services. We don't believe that. Okay, because it's in the providers and the facilities' best interest to provide the accommodation. Again, think hearing loss. You know, I for a doctor to ask me if I have any allergies to medication, if I don't hear that correctly and I give the wrong answer, I have a problem, the doctor has a problem, and the facility has a problem. Okay, so we encourage facilities to provide devices. I know in one hospital's doctors use their own phone and they have their in-house internet system. So people don't have to be worried about people, you know, being able to go in and record or see what's being said and privacy issues. So this is something that's being used more and more. Okay, next slide, please. This, if you can see down in the lower right-hand corner, that is a portable hearing loop, okay? And what that does is, it's kind of a complicated process, but there is a sound source. It's done in theaters, it's done in all kinds of places. But what it will do is it will pick up the signal from the voice of the provider, and then it will send that signal directly to the person's T-coil. So a T-coil is just a tiny coil that is in most hearing aids and cochlear implants, not all. So if you're requesting a hearing aid or an implant, you always have to make sure you have a T-coil. So the patient activates the T-coil. I can turn it on my cochlear implant processor, or I can turn it on with my telephone. And then what it does is the signal from the sound source, in this case, the receptionist, her voice goes directly into my cochlear implant, and it's clear as a bell. So the room can be really noisy and chaotic, but you will have a much better chance of hearing what's being said. There are theaters, hospital conference rooms that are fitted with room loops. So anywhere in that room, you could hear what's being said through that signal. But that's expensive, and not all facilities want to do that. So to have a couple of hearing loops, either maybe at a reception desk, because the patient sees that little icon there with the ear with the line going through, and the T, which symbolizes that there is a telecoil there. So you should activate your telecoil. So this is great. It could be at a reception desk, or you can have a couple elsewhere in the facility. And if you're meeting with people with hearing loss and they have the capacity to use a telecoil, again, not everyone has one on their device, then you can just activate it, and it helps tremendously. I've seen them on conference tables and things like that, and they work wonderfully. Okay, next slide, please. Okay, this is CART, computer-assisted real-time transcription. This is the gold standard for captioning. This is actually a photo I took when I went in for my cochlear implant surgery. You can see the nurse. The blue screen is her computer, and then on her laptop, she is reading what the CART person is transcribing. So that can be done either live or remotely. In this case, it was done remotely. I was in New York. The CART transcriber was in New Jersey. You can use a phone for the audio source, so the CART transcriber can hear what's being said. Then they type on one of those stenographer museum machines, and it's just about in real time, very little delay, and it's quite accurate. And again, you could see what's being written, so you can correct any errors. It was life-changing. I had to really push to get the accommodation for my surgery, even though I was going in to get a device because I was deaf. But the nurse was thrilled to see it. My surgeon came in beforehand, and he was thrilled to see it. Also, when I woke up from my surgery, I completely forgotten that my son was there, and he was my support person, that he would not be able to stay in the hospital. This was towards the end of COVID, and the hospital really understood at that point when I needed, because when I woke up from surgery, there was a nurse sitting by my bed with a laptop, and I thought, oh, I'm going to have to answer all these questions. Why didn't I think to have CART? And then the nurse typed something, turned it around, and in these large fonts, it said, "Hi, Tony, how are you feeling?" And it was so wonderful because I could have a whole conversation with the nurse because I had the access that I needed. Okay, next slide, please. I'm going to have to speed this up a little bit. Caption telephones. These will, again, there is either, it's mostly done with AI now, but as you are speaking on the phone with someone, you will see what's written on the screen. CapTel, can't think of the other one at the moment. There are a couple of companies that make these. If you qualify as someone with hearing loss, then the service is completely free. It's a federal program. I know one hospital was able to get a couple for their facilities, but it's mainly for people that have the hearing loss. So I'm not sure exactly how that would work. We could find out. When I went into the hospital in 2006 to get the steroids, I don't know what possessed me to do this, but it was one of my best ideas ever. I unplugged my caption phone, threw it in my bag, and took it to the hospital. So as a result, for the entire week, I was able to talk to family and friends on the phone. Otherwise, I would not have been able to communicate with anyone outside of the hospital. Next slide, please. This is an alerting device. It's the one that I have by my bed. When I take my implant off at night, I'm completely deaf. What happens is it Bluetooths to my smoke detector. If you can see on the upper left, there's like a little bump there that sticks up over the letters S and M. That is a very powerful strobe light. And I will tell you, it has woken me up when there was a false alarm on the smoke detector. Also to the lower right, that round thing is vibrator, and I put it under my pillow, and that also goes off. So again, I'm not sure, what the facilities are like where you are, but if a patient has hearing loss, it's something very good. It could just very easily be moved around to alert patients. Also, they can be flashing lights over doors and stuff. They even put them in hotels now, but it's extremely important. People in my building know that I'm deaf at night, and they know that if there's a problem in the building, hopefully they'll have time to come and get me. So that's important. Next slide, please. Okay, 2 quick things. Captioning on all video communication, whether it's the the TV in the waiting room, if it's a TV in a patient's room, or an instructional video for the patient, mandated that it has to be captioned. If they're instructional videos, it is up to the producer, the person that creates that video, to put the captioning on it. So if you're not getting it, call up the company that did it and demand it. Lastly, on this page is caption telehealth. This is extremely important. If you think of this meeting as a telehealth appointment, I could not do this appointment, and neither could Peggy unless we had captioning. So a lot of hospitals are not on board with this, and they need to be. One thing is the FCC, Federal Communication Commission, has issued an order, and in September, I think it is 2024, all platforms in the hospitals will have to have the capacity for captioning telehealth. So that is good because it takes the responsibility off the hospital and puts it on the platform. The hospitals just have to make sure that the platforms are doing their job. Okay, next slide, please. Environmental strategies. These are really easy, simple. Always reduce background noise. Even a hearing aid or an implant can sometimes amplify background noise in more than the voices. Second, optimal lighting in a room. In addition to overhead lights, it's really good to have lamp kind of lighting so that the provider's face is lit directly and never backlit, because if there's light behind it, it just wipes out their face. So you have no capacity of speech read. And lastly, movable chairs. These are all simple, free things. The example I gave with my doctor, he simply moved his chair and solved a communication problem. So very helpful. Okay, now we have a poll, another poll, I believe. Michelle, can you put that up? Okay, here we go. The question is, do you feel comfortable asking individuals if they need assistance with communication access? First response is yes. You feel comfortable? No, you do not feel comfortable. Third is, I don't have time. Then I need more ideas of how to do this. And lastly, we have great conversations about access. So please go ahead and complete that.
This is
Just to
Michelle.
comment.
This is Michelle. It's showing the same poll again. Let me try to take this down and put the correct poll up. Apologies for that.
Oh, I thought so. I'm sitting here reading this. Okay, I'm saying this is very familiar.
It really likes the first poll question. Hold on just a second. Every time I say long,
Well, I'll just keep speaking. All right, so should we just let this go?
We can do it at the end if you want.
we
Okay.
we could also do it in the chat if you want. The
Yeah.
question is, are you confident that you can access the aids and services your patients need in order to communicate effectively? Are you confident that you can access the aids and services your patients need in order to communicate effectively? People are saying the only response I'm seeing on chat is no. Nope, because of nonprofit. So a lot of people are not confident that they can actually get in place what is needed. So that is something we can be working on together. And just in the interest of time, let's go ahead and move forward, Tony.
Okay, all right, we'll take the next slide, and I'm going to just do this in 30 seconds. Okay, securing aids and services for patients and companions. I'm sorry we didn't get to this in more detail, but the ideal situation, and I think Peggy touched on it before and probably will some more, is to work with your patients on developing a communication access plan. There is one that's available in the guide, which I believe Michelle has shared with you, where it asks patients to identify their hearing loss, to talk about what accommodations they need, also to find out if people are in inpatient or whatever, that somebody has 2 hearing aids or a hearing aid and an implant, so things don't get lost. But the key is it doesn't specifically have to be this particular communication access plan. The thing is to get the information for the patient. And if you have access to EHRs, that's where it should be, electronic health records, and it should be red flagged. So no matter what you use, it should be in there. Also, so like the experiences I've been having with this one hospital for 10 years, I'm still getting interpreters instead of the access that I need. Secondly, find the person in your facility who can help with aids and services. Hospitals are mandated to have disability coordinators, but that may be different for you, but we can talk about that in the future. Also to develop relationships with hearing health practitioners so you can learn a bit about how people have to maintain their devices, and then to advocate for standard communication access protocols in your facility and beyond. I truly believe that with wonderful people at your facility and all over the country that are really working on this issue, that we will improve communication access and that we will get it done. So thank you. Peggy, back to you.
Next slide, please.
Oh, so that's the cap. Just skip that. So we're not going to go over that. Okay.
This is Michelle. I do want to take a moment to look at the CAP because
Okay.
we are encouraging all of our providers to use some form of this, whether it is this exact form or one that we work on developing together. But it would be wonderful to have these in your electronic health records so that you know exactly what people need. Questions that you may add could be for people who use interpreters. You could include names of specific interpreters they prefer. You can also include things like if they have a hearing aid on, like it says already, the hearing aid on the right or on the left. So these are really great guidelines to get that conversation started, and then to start working as an agency or an organization to get those accommodations in place.
If I could just add one thing to that, Michelle, when this was created, which was quite a while ago, the person that I created it with, Jody Prysock, was a sign language interpreter. So this was very much focused on hard of hearing and deaf. Some of it is also a bit, it really should be revised. So if you would like assistance in creating a form that would be more particular to your facilities and that would work better with you, and then to try to get this built into your IT or whatever, we'd be very happy to work with that and to get it updated.
This is Michelle. Wonderful.
Okay, next slide, and then we'll be back at Peggy.
Okay, so we're going to talk a little bit about evaluating aids and services that you select for your patients. I just want to make one comment before I continue, and that is that we realize that this is an overwhelming amount of detail and information. And one of the things that has come up consistently in our collaborations with some of our affiliations is that hospital and healthcare systems settings are very busy places. Nurses in particular are often sort of overwrought with things that need to be done for patients. My son-in-law is a nurse, and he talks about this a lot. But all of you are going from appointment to appointment, and this is just a tremendous amount of information to process. So I guess if there's one takeaway that Tony has emphasized, and I want to repeat here, is that what you want to really be doing is thinking about building a relationship with your patients around communication and creating a plan together, and start with low tech if that's all you've got right now. Building a plan together that's going to facilitate this asking questions and giving information back and forth that we talked about at the very beginning of the presentation. So this slide begins the section of our talk where we're going to just briefly address a process of what happens once you've got some accommodations in place and you're moving through time with your patient. Part of what you can do to build this sense of trust that we talked about is to keep checking in with your patient about the accommodations. Are they working? Is there something else we can be doing to make communication better for you? And have that message be a kind of strand that you weave through your various appointments with your patient. There are a couple of principles to keep in mind as you're evaluating how well things are working. You want to make sure, and you probably already know this, that your patient has a copy in writing that is readable for that particular patient about any follow-up instructions, any discharge materials. And you want to make sure that if the patient has suggestions about new things that you can be doing together to improve communication, that you get that into the medical record. Again, this is not about treating the hearing loss. It's about facilitating your treatment with the patient about whatever the health issue is more effectively, because you're establishing solid communication mechanisms with your patient. So one of the really cool ways to check and make sure you and your patient have communicated well during the visit is this method that Tony referred to, teach back. Some of you might be familiar with this. Thank you, Michelle, for forwarding that. It is, there's a lot of material available on the website of the Agency for Healthcare Research and Quality. That is a live link on the slide, so you'll be able to get to that page on their website very easily. And basically, this is pretty simple. Actually, it's simple, but it's hard to do. It's a way of not testing the patient's knowledge about what you've shared during a session. It's sort of a test of how well you've communicated with the patient. So I'm going to read to you two brief scripts about what teach back language might sound like when you're finishing up a session with your patient, or even in the middle of the session, when you're capturing information about different topics during the appointment. So the first script reads, "We covered a lot today, and I want to make sure that I explain things clearly." So it's not about the patient's ability to hear or to understand. It's about your ability to speak in a way that solidifies this good communication. So let's review what we discussed. Can you please describe 3 things you agreed to do to help you control your diabetes? So it's back and forth. The other script reads, "I've noticed that many people have trouble remembering how to take their blood thinner." So again, you're not putting it on the patient. You're talking about your experience in general in treating this particular issue. Can you show me how you're going to take it? So this is sort of the flavor of teach back. And I think that it's a very solidly studied method for making sure that healthcare encounters are as safe and effective as they can possibly be. This is used with a lot of different types of patients, not just patients with hearing loss, but the method has come up a lot in our conversations. I think the first time we ever learned about teach back was from Nick Reed, who is the public health researcher at Johns Hopkins. And it's just a sort of basic low-tech way for you to make sure that you and your patient you have this synergy in your communication with each other. Next slide, please. And we can wrap up here by just walking through the ways that effective communication improves the quality of treatment for your patients. Definitely improve patient safety, informed decision-making. It really establishes a kind of platform for you and your patient to collaborate around communication per se. Treatment and medication adherence. If the patient trusts you and understands what the instructions were and is much more able to remember what those are, the patient will be much more likely to adhere. Increase patient satisfaction and trust, and generally better healthcare outcomes. So that's the end of our presentation. I believe that Jeannie is going to talk a little bit about her peer mentors in Kentucky and HLAA Kentucky and the ways that she can support your work.
Hi, hi there. Thank you all for your presentation today. So I did want to take this opportunity to give you a little bit more information about some of the resources that are in Kentucky. Currently, we have 2 active Hearing Loss Association of America chapters in Kentucky. One is called the Kentuckiana chapter that's located in Louisville, Kentucky. The other one is here, Kentucky Home chapter, which is located in Bardstown, Kentucky. Those are 2 active groups. In South Central Kentucky, where I live, there's not an active chapter, but there are 2 representatives here, me being one of them, so that if you are in the South Central area, that you could contact me for additional information. And I'm assuming that Michelle is going to share that with you all. Also, before the presentation started, Peggy and Tony and I were talking about our time at Gallaudet University. We all 3 are certified peer mentors for the deaf and hard of hearing. And it's simply a training program for qualified people to learn how to help others who are experiencing hearing loss, helping them learn how to navigate all the new things that they may be encountering. It is especially important to the advisory committee that we provide resources for those who are in the mental health care system. And as you all can tell from the things that our presenters introduced today, those plans are going to be very, very important for you to have in place, because you will have already established what the patient's need is, or you all may call them consumers, or whatever you call the people that you are treating. So you can see the importance of having a plan in place, identifying their hearing loss, identifying the things that they need to have access to the therapy that you're getting ready to go through with them. So I am certified. I think I'm one of 3 in the state of Kentucky, and Michelle and I have worked together for many years, and she will most likely share my contact with you. Thank you.
Thank you so much, Peggy, Tony, and Jeannie. We do have, there's 2 different kinds of peers we're talking about here. So the peer mentoring project through Gallaudet University is specifically for people with hearing loss and mentoring others with hearing loss. In our mental health world, we also have certified peer support specialists. And so when we're looking at that intersection between mental health issues or substance use issues, lived experience, and then also having hearing loss, then we actually have partnered with Bridgehaven here in Kentucky, and we are growing our peer support network. I know at least one of our newly trained peers is on the call. She's currently working at 7 counties. So lots of our language today was around patients and medical situations. We know that behavioral health care is healthcare. And so you can adapt what we were talking about to whether you're talking about a member or a peer or an individual. All of that is really critical. And you all had a couple questions in the chat I want to make sure that we get to. One was, have you found a good app for noisy environments or with groups?
Tony, do you want to take that?
Okay, environments with groups. Well, again, it depends. You know, your clearest method of communication for those that can read captions is captioning. And in a noisy room, a speech to text app probably won't work because you're going to pick up other noise and it's difficult. So CART is one option for that. If people have access to a hearing loop, it's great to have a portable hearing loop. Beyond that, there's really not a lot that you can do. I have a mini mic that comes with my cochlear implant, and that I can have one person wear it. And if it's a noisy room, I will hear that one person, but it does not work for multiple people. So if at all possible, you just have to do whatever you can to get that person into a quieter environment, or even using a whiteboard. I had that pre-surgery once, and it was very helpful. Last minute instructions. Peggy, you want to add to that?
Yeah, I'm just thinking about something. So there are a few hospital systems in the country that are doing an amazing job with communication access, and we sort of keep our eye on what they're saying to help us know how to answer these types of questions. I just recently heard a talk with Mike McKee, who's at University of Michigan Medical Center, and he stressed the use of Live Transcribe as being the best voice to text app. Now, I don't use it because it's only Android, and I don't know if it's particularly good in noise, but if you have an Android phone, you might want to try that. Also, a lot of this is trial and error, and it takes time. And we're very aware of the fact that there's a lot on you to make this happen. So you need to be good to yourselves and do one step at a time and evaluate what's working, what's doable, what's accessible. If you have Live Transcribe, give it a shot and let us know if it's good in noise.
Or
Thank you. Hold on. Thank you so much, Peggy and Tony. You have one thing to add?
yeah, I just want to add one thing. I always encourage people who are hearing to try some of this stuff. So try Otter AI or try Live Transcribe on your laptop when you're with your friends and just see how it's coming up. Do it in a quieter place, in a noisy place, and just see what it feels like. And that will help you to get a better sense on how to manipulate the environment, etc. Okay.
So I know that one of the things I'm getting questions on in direct chat as well is, how does this apply to mental health? How do we adapt this with mental health? And that's the ongoing conversation. So I know, like, one of the challenges is that one-on-one communication is very different than in a group. And so that can be a future follow-up. One of the things is thinking about what is the best match for an individual. So if you have an individual with hearing loss, you want to think whether or not group is going to be the best format for them. It may be that they really need individual more, or it may be that you need to have some really strict limitations on how that group runs. A psychoeducation group is often easier than a mutual support group. That's another place where you could think about having CART, where you can think about having multiple techniques and realizing that one size is never going to fit all. And one room is going to be different than another. If there's 5 participants, it'll be different than if there's 10. So it's a constant process of adapting. I really encourage everyone to start thinking about these things. Go back to your team meetings, talk about the training, talk about what you learned, and think about how we can come together again to adapt this to your setting and to the folks that you're working with. I'm going to put together a toolbox of resources based on the conversation we've had, with links to some of the things that Tony and Peggy have mentioned today. And you will also receive a copy of the slides so that you can go back and review that information. We have recorded today, and that will be available on our YouTube channel if you want to go back and view it, or if you want to share this with someone else. And I put my email in the chat so that if you have additional questions, you can also reach out to us about state-specific questions, as well as the general questions for Peggy and for Tony. The last question I saw in the chat was about alerting systems. Are there any alerting systems tied to the NOAA weather radio?
I don't, Peggy, do you know about that? I'm not aware
know.
of that, but I will find out.
I know that within Kentucky, the Kentucky Commission on the Deaf and Hard of Hearing is working with NOAA for accessibility. So that can be a conversation we also have with the commission as we do that research. Peggy?
I just have one final comment. I think it's my final comment. I don't know because I'm not a mental health professional, but when we were planning this session, one of the things that we talked about was the fact that the collaboration with the patient, in other words, the patient is the expert on his or her hearing loss or communication needs. And so it's a process and you're working together. And I can only imagine that for some patients, that builds a sense of self-efficacy that's so greatly needed in our mental health population. So it's just a side note. I don't know about the treatment, the science of treating mental health disorders, but I do suspect that having a sense of agency about one's inability to hear is another possibility for helping a person achieve wellness. We know that there are much higher rates of depression in hearing loss population, so it's possible that hearing loss could be a layer of depression issues.
Thank you, Peggy, for pointing that out. And I think I always encourage targeted case managers, peer support specialists, therapists to put in goals on the treatment plan around self-advocacy and to encourage those case managers and peer support specialists to help with navigating the system. And we'll put some resources in that toolbox as well to help you all have those conversations. I'm so grateful to you, Peggy, you, Tony, and to Jeannie for this great conversation. I know that it's just getting people thinking about what's all possible. And whether we're in a hospital setting, whether we're in a medical appointment, whether we're in a mental health appointment, or in a recovery center, there is so much more we can do to improve communication access. And I am grateful for the project and for Hearing Loss Association of America for bringing this to everyone's attention. Any final comments, Tony or Peggy, before we wrap up?
Just thank you for the opportunity. We love doing this kind of work, and we are available to answer questions at any point in time moving forward.
I will just second that and say thank you. You folks are the people, your boots on the ground. And the work that you do is really challenging. And we want to make this easier for you as well as for your patients. And thank you for being so true to this important issue.
Thank you to Jessica and Julie, our ASL interpreters, and to Jenny James, our CART provider. Thank you all and have a wonderful rest of your day.
Bye-bye.
Bye-bye.